So we're talking about geriatric emergencies. Geriatric obviously means elderly. They do have a different presentation and different risk factors for different types of injuries. So it's good to know a lot about them. Also, statistically, I want to think 1/3 of the patients that you will encounter in EMS are going to be over the age of 70. And that's anywhere you work. That was just a compiled thing. But so 30% of your people are going to be over the age of 70. So it's kind of good to know a little bit about them. So there you go. After age 30, organ systems lose 1% of their function each year. So think about that. Your organ systems could be your endocrine system, your cardiovascular system, your respiratory system. All that is not going to be nearly as efficient. So 1% of function each year. So you went from, think about somebody that's 70 years old. They're only 60% efficient of what you might be. And that includes, remember, your maximum heart rate declines. So anytime that they're in distress, their body cannot compensate as well because it cannot increase the heart rate to increase the cardiac output. So you definitely need to pay attention. You're going to have to dig a little bit deeper. Communicating with them, obviously, because they might have a lot of hearing problems, vision problems especially. So I would just ask them, don't assume that everybody can see and hear just like you. It could be reference to a stroke or dementia or anything like that, some sort of organic brain disease. But the best way to do is to talk to them. Don't assume just because somebody's confused, an elderly person, that, oh, they've just got dementia. You need to know whether this is new onset or if this is old. You're going to need to establish a baseline because a new onset of confusion could be anything from a stroke, some sort of metabolic condition, could be an infection, or something as simple as their blood sugar. But you need to be checking and be very, very thorough. So, scene size up, the biggest thing you need to do is when you walk in, you need to kind of look around and figure out what's going on. Condition of the residents. There's a lot of places that sometimes, if they're having a hard time functioning, that they're not going to be as clean as they normally can because it's just very difficult for them to do these things, these daily living and take the trash out. They might not be able to bend and stoop and pull it up. So you need to pay attention. Half-eaten food. Like I said, items left out that the patient can trip on is a big one. If you see things that somebody can trip on, you need to correct it, even if it's something simple as a rug. Straighten the rug back out, because if an elderly person falls and breaks their hip, that's a very catastrophic thing for their health, because now they can't put any weight on it and they end up having to go to a rehab home or a nursing home for a while if they ever come back out. So prevention is the key to everything. Y'all understand what your primary assessment is. When you walk in, how do they look? I mean, what's their mental status? Talk to them. Do they answer you? Airway, breathing, circulation. Do they look in any kind of distress? Are they pale, diaphoretic? Like I said, and remember just your ABCs in the primary. It's not just, hey, is the airway patent, clear, free of obstruction, breathing, equal rise and fall of the chest? Do they got good air movement? Do they look in any kind of problems? Is it at a fast rate? Circulation, what's the temperature of the skin? Is it cool, clammy? Do they have a good radial pulse? And that way you can, in just those quick few things, any variation of these three is what's going to make it know very quickly that it's a priority patient. Finding a radial pulse, no different. Nothing's different there. I mean, their veins and arteries have not moved, so you don't have to worry about it. As far as secondary assessment, you're probably going to have a whole lot of medicines and stuff. So you need to really sit there and think about it. Find out whether the patient is compliant with medical advice. So just because they've got pills for blood pressure, let's say, doesn't mean that they're taking it. Well, their blood pressure's high. Well, they're on pills for it. Doesn't mean that they take it. I've had people that I go out there and they don't like the way it makes them feel, so that bottle is old. So they just don't take it. Asking family members is going to be beneficial. Usually, there are those rare cases where families don't really seem to know anything about their family. It's their elderly parents or something. It's really weird to me, but so check in when you start looking. Remember, start head, neck, chest, abdomen, pelvis. There's at extremities. Hip and proximal femur is very, very common because weakening of the bones. The bone mass has started decreasing, which makes them so much more fragile and just all around. But when somebody goes to fall and they put their hand out, then break the wrist. That force can go on the wrist from trying to catch themselves or landing on their arm and breaking their humerus and hip and proximal femur. It's horrible, but it's going to be very, very common that you go out to finding somebody, an elderly person who's got hip pain. So you need to be very careful. Head and neck, when you're looking at this, you see that there's that KED that we had used in class. They've got her on a non-rebreather, still holding manual C-spine at that time. And then you can see the firefighter in the background. He's checking a radial pulse right there. It's not just, hey, how fast is it? The average heart rate's between 60 and 100, but hers may be a little bit different. But what's the quality of it? Is it strong? Is it irregular? Is it very weak? Can I find one? If I don't find one, and her skin is cool, pale, and diaphoretic, then that might be an issue. So, shingles is similar to the chickenpox virus, or I guess is, and it reappears and comes back in these weird band shapes. So it says belt-like because of the way the nerves that it follows. But I've never had it, but I've heard that it is very, very painful. So be very careful with it. So pelvis and extremities. So don't forget, when you're checking extremities, edema, because it's usually going to go to the lowest place, especially if somebody that walks or does anything, then the fluid's going to go to the lowest part. It could be because of kidney failure. It could be because of congestive heart failure. There's a lot of different reasons. If it's just on one side swelling, it could be a blood clot. There's so many different things, but it's something that you should definitely note. Remember, spine, decreased mass, not very well protected anymore, very commonly injured. So abnormal curvatures, what they're talking about is there is some people, and everybody's kind of noticed the elderly person that's kind of slumped over a little bit. It's called kyphosis, and they're kind of hunched over, kind of like a hunchback. And think about how you would try to immobilize them, how much difficult, because you can't force them back. I mean, you go try to push grandma flat like that, you're going to snap her like a pretzel. But you're just trying to motion restriction, not force them to lay flat as a ruler. And make sure you continuously keep a constant reassessment. You can check vitals every 5 minutes, stuff like that. But you need to be constantly talking to them, checking them, just observing. And notice whether you see any change in them. So it says talking with the patient can be therapeutic for the patient and enlightening for the EMT. So it's good for them. They're going to feel better because they want to talk. And it's more of a comfort thing. Don't be that creepy guy that just sits there on the bench seat and looks around and is quiet the entire ride, because there's nothing comforting there. People want to feel good. So talking to them And also, the more you talk to them, a lot of times they're going to come back and you might kind of piece together more of what happened, or there might be something crazy that was actually the root of the problem. One doctor that I'd listened to, and he swore by it, and it makes perfect sense. He says, if you talk to somebody long enough, they will tell you what's wrong with them. You just have to pay attention. And I think he's exactly right. They just have to give us all the clues to the puzzle, and we'll piece it together. But you have to talk to them. If they don't thank you for coming out when you drop them off, then you should probably reassess your patient care. So start thinking about it. Commonly seen when assessing elderly patients' blood pressure. It's usually pretty low, or it could be kind of high. It might be their normal, but a lot of times they're going to be on blood pressure medicines. And then we already talked about what's the most common fracture in female. I would say hip. And then we already talked about you might face what the challenges you might face for immobilizing elderly patients. So remember, they're prone to some problems because of age-related changes. 1% is what they're saying. That's not exact, but everything is decreasing. Remember I told you, it's like once you stop growing, you start dying. It's kind of depressing, but people are going to present differently. They might be very vague. Vague signs or symptoms is a very big one right here at the bottom, because they might be having a heart attack. If you are over the age, if you're elderly, diabetic, or a female, you have a higher likelihood of having atypical symptoms for cardiac issues. So just because grandma's saying my upper back hurts, that doesn't make sense. Well, unless grandma's been, doing butterfly curls, then or injured it in some way, there's no reason her upper back should hurt suddenly and have like a sharp pain that's in there, and that's odd. You need to think it might not be a heart attack, but you still need to think about it and keep doing reassessment. Hey, does anything you do make it better or worse? And that's when you start doing your OPQRST, start going through everything just to piece it all together. Drug patient interactions. Sorry, Donna Rose was emailing me. No matter, I could be on the phone with God. Donna Rose calls me. I click over and see what she needs. So drug patient interactions. Remember, it says inability to clear medications from the body as quickly as before. So that's a real thing. Like, let's say it's how is the drug metabolized? So pain medicine is primarily through the kidneys, and that's how it comes off. I used to have a very sweet, very, very sweet old lady that would come into the hospital about once a month in the ER, about once a month or every month and a half, and her husband would pull up and say, hey, here she is, and this woman is out cold. She is snowed, sleeping, because she's got too much pain medicine in her system. It wasn't because she was overdosing herself. She was taking them for chronic pain, and it slowly would build up to the point because her body wasn't eliminating it as fast as somebody normally would, and she would have an overdose or a large amount in her bloodstream that would cause her to be altered mental status, lethargic, and could affect her breathing. It wasn't because she took too many at once. She just slowly built it up in her system. And they'd put her in the hospital, put her on a Narcan drip, let her kidneys catch up, send her home. But there was nothing they could do. It was either deal with this every 90 days or whatever. Not 90 days, every month and a half, or she's going to be in chronic pain. So, drug interaction. So two drugs interact. So sometimes you might have two different doctors that are prescribing stuff, and they might have adverse reactions. So it can happen. right. So this is called polypharmacy. There's a lot going on there. So just looking at it, I mean, you got to think of all the different things. It looks like eye or ear drops. I don't even know how much to count, but she's got a lot going on here. Just me walking up, and I'm not going to divulge my age. I'm old. But this would confuse me. And I'm not even 80 years old. So imagine that. Trying to figure these out. How are these sorted out, when she knows when she's not supposed to take them? A lot of different things. I will say one thing I do notice just from this picture is when you look at this bottom one in here, that medicine bottle has been flipped over the lid to make it easier for somebody with arthritic hands to grab it. Some of these are like that, some of these aren't. So it makes me wonder if she's taking them. So it'd be just a good question to ask. So shortness of breath, it can be, like I said, most people, shortness of breath when they're older, it could be heart attack, it could be a pulmonary embolism. Pulmonary means lungs. Remember, embolism means blockage. Usually a blood clot is moved from somewhere in their body and has made it to the pulmonary system. They could have COPD, emphysema. It just depends. Remember, if somebody elderly is having chest pain, it could be anything. Angina could just be, there's some people that just randomly have chest pains and there's nothing, it's not cardiac related, it's just they have a history of it. Or it's not like, it can be cardiac, but it's not anything that's like an immediate life threat. They usually handle this stuff at home. But it may be a symptom of something worse. Myocardial infarction, obviously myo means muscle, cardial means cardiac, so heart muscle, and an infarction we already talked about is the blockage and the blood flow and is causing it to starve and become ischemic. Pneumonia, everybody should know what pneumonia is. Biggest thing is also they can't breathe, they end up developing chest pain, they can also become hypoxic. Aortic aneurysm, we've already went over like the blood flow, so their aorta ends up having an aneurysm where part of the vessel wall is blown out the side. Think of all the different things that can cause altered mental status. We talked about it earlier, like don't assume it's just dementia or anything. Can be from medications, low blood sugar, stroke. There's all different things. So if somebody's altered and it's not a new thing, I mean, it's not an old thing, chronic. If I ask her, fine, like if I ask her her name and she tells me Tuesday, and I start talking to the family and said, no, she's always fine. She's actually a rocket surgeon and got home from work this morning and all this just started, then I should probably be concerned. I can't assume that it's just old age. So remember that aneurysm comes down and then you have the abdominal aortic aneurysm. That's big main pipes coming through there. Bowel obstruction is a big thing with elderly people because their bowels are not moving. I cannot think what it's called, but there's something like peristalsis. And don't quote me on that, I might be wrong. But the bowel is not moving the contents forward, so it can result in a blockage. Diverticulosis, you can have like the polyps and everything in there. They are at a risk of internal bleeding. A lot of these people are on blood thinners, so that puts them at a higher risk. And then, there it is, they could be cancer. They could have ulcers, could be bleeding, or adverse effects of medications. It could be constipation, because one of the main side effects of pain medicine is constipation. Dizzy, weakness, or just not feeling well. you need to take that seriously. Oh, she's just weak. It's fine. She's old. No, the sudden onset of weakness is not normal. You shouldn't just be walking and then suddenly feel like somebody zapped all your energy. That's not normal. So it's better to err on the side of caution. Just kind of do a good, thorough assessment. Depression and suicide is a lot more common than you think. So think about it. You spent your entire life and working and being fully capable for yourself, and now you are living in a repurposed shipping container behind your kid's house. And you can't get up, you can't go for a walk, really, you can't do anything, or you feel like a burden. And it's depressing. You feel, a lot of people feel like a burden. Or their medicines. Medicines might make you feel bad. And by then, I hate to say it, but kind of after a certain point, everybody you knew died off. And especially your spouse. You spend the same amount with somebody for 50 years, then what happens? You're alone. Or it could be just a simple chemical imbalance. So there's back to the shingles thing. Remember, it's that belt-like band because it follows that nerve. It's like the dermatones. If you're wondering about dermatones, look them up. Remember, it's part of the peripheral nervous system that comes off the spinal cord and follows and innervates different things. That's why it appears like a belt. But it's very, very painful. It's usually on the stomach like that. EMT can contract it from fluid. So, you should have been wearing your gloves. And that means don't wipe it on you. It's interesting. Death may result from complications of a fall. Yes. So bruised ribs, cannot cough because of pain, develops pneumonia. Very, very common. Very, very common, actually. So because it's what it's called is like coughing is a very violent thing and you need to take a deep breath. Well, you end up setting up like this bacteria in there and you can't cough the secretions out. Because if I take a deep breath, it hurts. And I can't have that forceful cough. So I end up developing pneumonia, and eventually it gets worse. If suddenly somebody fell, why did they fall? Did they pass out? Did they trip over something? You need to figure it out. Sometimes it says abnormal heart rhythm. Sometimes they can go into a rhythm, an abnormal heart rhythm that is not very efficient and causes their blood pressure to spontaneously drop and causes them to get really weak and fall. They might have had a stroke walking. Who knows? You just need to figure it out. Elder abuse and neglect. So happens a lot. Physically, there's a lot of places and people that will physically harm elderly people. They yell at them, which would be psychological. It's going to be related to their mental thing. Or financially. Basically, they, shove grandpa in a closet and collect his check. And take all his money. And there's nothing he's going to do. So it can be difficult to detect. Remember, this is when you just got to start asking questions and just talking. If you do have suspicion, then I would go ahead and transport them to the hospital. And remember, you're bound by law if you suspect it to report it. You don't have to mention it to the family, but just kind of talk to them and get them to the hospital. So think about it. They're taking care of each other. One starts getting sick, one takes over. They're going to take care of it. And now the caregiver gets sick. Now who's going to take care of both of them? Caregiver guilt or burnout is a big thing. Especially burnout because they're stressed out. They've got so much going on. They're stressing about everything. They've got to get medicines. They've got to do everything. And guilt. I'm not doing a good job. or something happened. I've had a couple people, well, recently I had a very sweet couple that he was having some trouble and he had COVID pneumonia. He wasn't doing very well. Ended up having to call an ambulance for him. And one of the first things the wife said to me is, "It didn't get this bad until last night." And I said, "Okay, that's fine." And she said, "I knew I should have slept in here." And she was pretty much focused thinking that it was her fault because she didn't sleep in here, and that's why he got sick. That's why he got so much more. And it took me a while to convince her that everything she did was fine, that there was nothing that she could have done differently, and she had done an amazing job. And she said, "Well, thank you for saying that." Unfortunately, he actually never made it back out of the hospital. So it sucks. You thought that was going to be a good story, didn't you? So there's that more shingles rash again, all across his face. Remember, these people worked all their life independent, doing some really cool stuff. Who knows? They didn't need anybody, and now they're to the point that they require help. Treat the patient with dignity. Do not call them baby, honey, stuff like that. Don't patronize them. Yes, ma'am, no, ma'am, yes, sir, no, sir. Call them by their last name, whatever. Like I said, make sure. A lot of people are going to, "Well, I can't go, I got to do this." Lock up the house. Arrange care for pets. Make sure, empathize. Be reassuring. Make sure everything. Call whoever you want. Whoever they need. "We're going to do this. We'll make everything." "Ma'am, I need you to go to the hospital." "Well, I can't. I got to do this." "We'll take care of it." And they become very, very scared about it. So here's some things I want you to think about. I'm not going to talk to you about them. I want you to go find them. So think about all the different things that are different when treating elderly patients and preventative measures for an EMT that comes in contact with shingles. And this is a fun one. What is a side effect of NSAID use? So you need to look that one up. Should be on your drug cards. So Alzheimer's, memories, confusion. It can be little bits. It's not just suddenly nobody knows their name, anything like that. Don't assume. Just err on the side of caution. Try to get a baseline. Is this a sudden change, gradual change? But they may not recognize friends and family. They may be scared. Try to coax them. Be nice. Elder mistreatment and abuse video. So it actually looks like they're in a facility in this one. Pretty common. All you got to do is watch the news, and a lot of times you'll see nursing homes and staff that are abusing elderly people. But it's not just nursing home staff. It's also very, very commonly at home. All right. So start going through all these different things, and I would learn and read about them.